comfortable putting a focus on ourselves. So for example, some people just have a personality type where they put others first. Some people are professional caretakers, social workers, nurses, teachers, where you just naturally put other needs first. Or people who are in rescue occupations, people who are trained to go into dangerous situations to save the lives of others, have a tremendously difficult time focusing back on what's important to them. And I think for, in the PTEN community, one very specific way this plays out is for those of you who do have a child who is autistic, there's a lot of work that goes into the kinds of routines that you need to put into place to make your day move smoothly and make the family function smoothly. All the time that you put into advocacy with teachers and with schools, all the medical appointments you have to go to, and so you wind up focusing so much on the child that to turn the attention back on yourself, it's almost like you get out of the habit of that. All right. Another thing that happens when you have a big decision to make is that it can expose sort of areas of weakness in your life, either ways of coping that maybe don't serve so well, or sometimes it can expose a problem in a relationship. I had a patient once who, the night before she was going to get married, was having lots of second thoughts about it, but she said, everybody's already here, so I might as well just do it. And come to find out, her gut instinct was right. This man turned out to be verbally abusive, and it took her several years to get out of the relationship. So then when she came to making a surgery decision, she realized she didn't trust herself anymore, right? And so she had to kind of repair that relationship with herself before she could really move forward. One way I talk about this is a decision is like an earthquake, and it shakes the building. Anything that's strong stays standing, but if there's any weakness in the wall, it'll fall down, right? And that may have been there for a long time, but this exposes that area of weakness. So sometimes you wind up, when you're thinking about medical decisions, your mind is traveling to things that don't seem to be related. It's because of that shaking motion that's bringing things up to the surface. Another thing that happens is that genetic mutations are not the only kind of stress that life has to dole out to people, right? You probably, there are other things that have happened to you. I see patients who come in who've had, maybe they had a severe car accident 10 years ago, and they're finding that that's affecting their ability to adjust, and it's affecting their ability to make a good decision. So this is a different way, and this is just the way our nervous systems are designed, is that these multiple stress hits actually affect our ability to tolerate new stresses. For those of you who are in relationships, this is a very specific interaction that will happen. A woman will be thinking about having a bilateral mastectomy. She goes home to her husband and says, honey, will you still love me if I don't have breasts anymore? And for the guys, that's like a gun to the head, right? There's only one right answer. Of course I'll love you. But she knows that he knows it's a gun to the head, so she's not reassured even though he said the right words. And then you've got like a deteriorating communication situation. So an important part of the decision when a partner is involved is to allow space for feelings. Allow space for a little bit of sadness. I love the way that you look, I love the way that they feel, but I do want you to do everything that you feel is important, right? That's a different communication, right? And usually when we get to that level, the couples, they'll start holding hands, they'll get a little teary, I get a little teary, and but you can see like a new closeness emerging in that moment of decision. So, and then the last point I want to make about decisions is the scary part of it is this is a one-way street. If you make your decision to go ahead with the mastectomy, it's not something that you can undo, right? So it kind of closes off certain possibilities. Now, of course, there's another way in which life is a one-way street, and that applies to all of us, not just those of us who have mutations, right? But that, this is the professionals, the researchers, clinicians, business leaders, congressmen who's come to visit us today. We are all in this human condition, right? That we all have to make big life decisions without knowing how they're going to turn out. And we all know that we're not all going to be here forever, right? So even in the isolation of having a rare condition, it's still what happens is that the rare condition is pushing you to think about what is really true for all of us. So in order to make a decision in that context, what I really look for is to make the decision meaningful. If you can say what your health decision, your surgery decision, how is that going to help you fulfill your life goals, connect you to other people, and give you a sense of purpose. Like a woman might come in and say, I want to make sure I've done everything possible to be around for my kids. That's purpose. That's a mission, right? So what I ask patients, this is one of my key questions, can you say in one sentence what your decision will do for you, right? And there's a different tone of voice that people, when they have that, that's that moment when the decision has emerged, it's gelled, and you can move forward with confidence. So what I look for is somebody knowledgeable. Are they informed but not overloaded with information? Are their expectations about the process realistic? Do they have a clear goal as to what this is going to do for them? And do they have adequate social support, at least one adult who can listen to you without judging, whether that's a partner, a friend, a priest, a psychologist, but you need that one person, right, to help support you through the process. So my take-home message would be that how you make a decision is as important as what you decide. So people want to know what's the right decision. The right decision is the one that lets you live fully, but how you make the decision is part of what makes it the right decision. If you go through a good decision process, that reduces your risk of having regret later. But even after you go through this, you still might get nervous, especially that night before. Am I doing the right thing? That doesn't mean that you're making the wrong decision. That means you're having a human experience of anxiety. But if this goes well, the decision process will give you a good footing so that no matter what comes next, whether it's a different kind of cancer out of left field, or whether you do have a surgery complication, or you choose surveillance and you do get diagnosed with cancer, even though you were hoping that wouldn't happen, is that you're in a good place to reach out and deal with the consequences of that decision. So with that, I want to say thank you very much and invite Dr. Peterson back up.
Are there any questions for either of us about breast risk? All right, well, we'll be around all day if anything comes to mind or if you'd like to speak more privately.
Thank you, ladies. Okay, we're going to switch it up for a minute, keep you on your toes. I'm going to stand down here for a minute. Next, we're going to talk about GI cancer risk and management. So Carol Burke, MD, completed medical school at The Ohio State University College of Medicine and Public Health, residency at Riverside Methodist Hospital, and her gastroenterology fellowship at the Cleveland Clinic in 1983, and has been on professional staff since that time. So Dr. Burke is internationally known for her work in the polyposis syndromes and is the director of the Center for Colon Polyp and Cancer Prevention. She has been awarded research grants from the National Cancer Institute and the American College of Gastroenterology to study the effects of chemopreventative agents on the prevention of intestinal neoplasia. She is the co-director of the Hereditary Cancer Clinic and provides consultations for individuals with a hereditary predisposition to cancer. She is the author of numerous peer-reviewed manuscripts, abstracts, and book chapters, and is a frequent reviewer for many digestive disease journals. Please welcome Dr. Carol Burke.
Thank you. My dad would be so proud of that introduction. Thank you very much. I actually was so honored to be invited to attend this conference. Kristen really batted one out of the park with this. And I'm also very lucky to work with a team of individuals at the Cleveland Clinic that are committed to improving the health and wellness of our patients with PTEN. My job is to actually reassure people about the GI impacts of Cowden syndrome and PTEN hamartoma tumor syndrome. And I'd like to put it into perspective. So about 5% of us will get colon cancer in our lifetime, this people without an increased risk of colon cancer, 5%. If you look at patients with a PTEN mutation, you can see that that risk is about double, but not much higher than individuals in the general population that have a family member with colon polyps or colon cancer. You can see that the other hereditary colon cancer syndromes, Lynch syndrome and FAP, have much higher cumulative lifetime risks of colon cancer. So that's the first bit of good news that I want to share with you, is that the lifetime risk of colon cancer is not too high and it can be prevented. 1 in 3 adults in the United States will develop an invasive cancer in their lifetime, and colon cancer and death from colon cancer is the second leading cause in both men and women in the U.S. And if you take a look at this graph, what you can see from the colorectal cancer, it's the blue line, third from the top, is that the risk of colon and rectal cancer has been declining in the United States for about 30 years now, almost 1% per decade, and it is occurring both in men and women, and you can see the onset of when the decrease in the incidence and mortality of colon cancer has occurred. The reason for that is because individuals are undergoing colonoscopy or having colon cancer screening. So this is one of the few cancers that individuals with a PTEN mutation are at risk of that can be diminished substantially and prevent it from even occurring or detecting it very early when it's curable. So how does colon cancer develop? This is just a little cartoon that shows that there's a little bump in the colon called a polyp. It's on the far left side of the screen. And as more mutations develop over time, the small polyp can lead to a big polyp and turn into invasive cancer. There are a variety of polyps that can occur in the colon, and the most common in the general population includes a type called an adenoma, or a hyperplastic polyp, which is a serrated polyp. But it's interesting in patients that have Cowden syndrome or a PTEN mutation. I don't mean any disrespect, but I call it the junk colon because it has lots of different types of polyps, and particularly if you have a colonoscopy and have been diagnosed with a ganglioneuroma, that's one of the hallmark polyps seen in the colon in patients with PTEN mutations. There can also be lipomas, lymphoid follicles, schwannomas, adenomas, as well as serrated or hyperplastic polyps. I'm just showing you a different picture of a type of polyp that can be seen in patients with PTEN syndrome, and that is the sessile serrated polyp. It's the flat polyp. Let's see if I have a little cursor here, and you can see these are very difficult to see. The person doing the colonoscopy picks it up just by this little rim of debris that's left over from the colon prep. These polyps can also just look like a funny fold on the colon lining. So here's normal fold in the colon and then this kind of broad fold. You can see that the blood vessels come in and stop right at the border of this, or it has a little bit of lacy blood vessel on the surface. And these types of serrated polyps are quite difficult to pick up either in the PTEN or the sporadic population, and takes a doctor knowledgeable about the syndrome and about these polyps to detect them so they can be removed completely. So what about PTEN and the colon? 90 to 95% of patients with PTEN do have colon polyps, and more than 50% of individuals have more than 50 colon polyps, where the average population will only have 1 or 2 over a lifetime. And so when someone has gobs and gobs of polyps in the colon, we call that polyposis, and those individuals that have gobs of polyps or polyposis need a colonoscopy endoscopy more frequently. And as I said before, it's the junk colon because there's a variety of different colon polyp types, the hamartomas, lipomas, lymphoid aggregates. I mentioned the ganglioneuroma. But the other thing you need to keep in mind is that over 65% of individuals with Cowden syndrome or PTEN mutation, I'm using them interchangeably, will also have upper gastrointestinal polyps, some that can be precancerous, and they can also have a polyposis in the upper GI tract. And these GI manifestations are so important that, in fact, they're part of the clinical criteria to make a diagnosis of Cowden syndrome. So having 3 or more gastrointestinal hamartomas, those polyps within the GI tract, is one of the major criteria. Colon cancer or funny white patches in the esophagus called glycogen acanthosis are part of the minor criteria. And here you can see a colon of one of my Cowden syndrome patients with a polyp here, polyp here, polyp here, polyp here. You know, you can see they're scattered throughout the colon. And then when you look in the esophagus, you can see these white spots called the glycogen acanthosis. The important thing about the glycogen acanthosis is it doesn't harm your health, but it can be a tip-off to us that my individual that I'm scoping may have Cowden syndrome. So I just want to take you through a quick view of the digestive anatomy. The esophagus is in the upper tract, and if you see on the right side of the slide, the white lining of the esophagus is merging with the red lining of the stomach. This is a picture of the stomach, which is where your lunch is sitting right now, and you can see that it has many folds in the stomach. That's with me retroflexing the scope to look back as the scope comes out of the esophagus. And what you can see in these images is these are all normal. You don't see many polyps, which I showed you in some of the other pictures in the colon. And then the bottom part of the stomach is a little valve that prevents your food from emptying from your stomach too quickly, so you don't have a rush of insulin and glucagon and feel indigestion and nausea. Then we move into the first part of the small intestine called the duodenum. And the small intestine is an important organ for many of the other hereditary cancer syndromes, not so much in Cowden syndrome, but you can see the folds of the small intestine, and that's where all your nutrients get absorbed. This is a little picture of something called the papilla, which is a really important structure in patients with familial adenomatous polyposis, one of the first hereditary cancer syndromes that was genetically identified. The pancreas lives there in the little hook of the duodenum, coming right around here. And what I've talked about so far are all the areas that can be reached with a scope, and I'll show you that in a second. And then you can see the colon or the large bowel. It's 6 feet long. It also is a hollow tube, and in this unfortunate picture you can see a 19-year-old patient of mine that had a colon cancer. That's that large bumpy thing that almost closes off the lumen of the colon. So how do we look in the upper tract of patients with Cowden syndrome? We use an upper endoscope, and you can see that's a picture of that thin flexible tube. It's hooked into special equipment. There's a light on the end, and there's also channels where we can pass instruments to biopsy, sample, or remove polyps if needed. That's an instrument going into the upper endoscopy, and basically when you're quite asleep and feeling very comfortable, you can see us looking at a monitor and taking an assessment of what we're seeing in the upper tract. The area in which the upper endoscopy looks is all the way to the first part of the small intestine called the duodenum. Colonoscopy, again, is using a thin flexible tube to look in the colon. The prep is required for a colonoscopy. You have to drink a laxative the night before the exam and stay on clear liquids. And you can also see from the front view of this scope, holding it out facing you, there's channels that we can flush, we can suction, we can also pass instruments in. And if we need to look in the small intestine, which is not recommended for most patients with Cowden syndrome, we also have the capsule camera, capsule endoscopy. And you swallow this pill camera about the size of a multivitamin. You're hooked up to equipment that looks like EKG leads, and that small battery-propelled, LED-chipped enabled capsule actually looks at the 14 feet of the small intestine between where we can get with the upper endoscope and where we can get around with the colonoscope to look for polyps in the small bowel if needed. And that's just some images from our capsule endoscope that shows a little red polyp down here. You can see a bigger red polyp here, and then you see the scope actually sitting in the small intestine, and I'm taking a peek of that with my upper endoscope. There's another view of some small bowel polyps, but that's how the colon polyps can look in our patients with hereditary cancer syndromes. And then we do have a variety of instruments that we can remove polyps and prevent cancer from developing right through the scope. The little tweezers is called a forceps. The lasso down at the bottom right is called a snare. So average risk patients should have colon cancer screening beginning about the age of 50, unless they're African American, when colon cancer arises earlier and is more advanced in its stage. Individuals can choose a variety of methods to have their screening, which is a colonoscopy every 10 years, a fecal blood test every year, and I've mentioned some other options, and those are all endorsed by a variety of national organizations. However, for our PTEN Hamartoma tumor syndrome patients, the NCCN, which you've heard a couple times already today, has come up with recommendations for what organ needs to be checked. And certainly, because of the slightly increased risk of colon cancer, a colonoscopy is recommended beginning at the age of 35, or 5 to 10 years younger than the youngest case of colon cancer in the family. And that's repeated every 5 years, unless you've had colon polyps or colon cancer when the interval between colonoscopies is shorter. So we have patients in the room that have Cowden syndrome. We may have spouses or advocates for individuals with Cowden syndrome. And so we also need to think about, if you have a family history of colon polyps or colon cancer not related to a hereditary cancer syndrome, individuals also need to have screening that might be more frequent or more intensive. So if you have a first-degree relative that has colon cancer or one of those advanced polyps, it's big or histologically advanced, some of those big or advanced serrated polyps, or with the first-degree relative being under the age of 60, or 2 first-degree relatives at any age, people begin their colon cancer screening at the age of 40 with a colonoscopy every 5 years. And then if the relative is older, so this is not pertaining to someone with Cowden syndrome, it's not the Cowden syndrome's first-degree relatives, but the advocate or the general population risk, then you begin at the age of 40 with the average risk options, which could include fecal occult blood testing. So I just wanted to contrast what we need to do for the average risk population and what the increase we need to do for patients with Cowden syndrome. And then based on the type of polyps you have, there's national recommendations about how frequently a colonoscopy should be done, and it's usually at a 3 or 5 year interval. But you can see the individuals with the highest risk of getting an advanced polyp or cancer, those with polyposis, 10 or more polyps on a single exam, they should be done less frequently than 3 years, and of course consider a genetic syndrome like Cowden syndrome. And then if you've had colon cancer, there is also recommendations for how frequently to be screened. And individuals with Cowden syndrome that develop colon cancer, of course, need to have treatment, which is usually surgery, and if lymph nodes are involved, the addition of chemotherapy or chemotherapy with radiation therapy for rectal cancer. So in conclusion, I want to let you know that colon polyposis is common in PTEN Hamartoma tumor syndrome. The polyps are a variety of types, and patients with Cowden syndrome have an increased risk of colon cancer, but colon cancer can be prevented by detecting the polyps and removing them before they turn into cancer. Upper gastrointestinal polyps are also quite common, and there's a variety of types, but upper intestinal cancer is quite rare, and we've published papers that we had 1 patient with a gastric cancer and 1 patient with an esophageal cancer, and so the NCCN has not made recommendations for doing upper gastrointestinal tract screening in Cowden syndrome. However, we're at the Cleveland Clinic a team of researchers that are interested in really understanding the manifestations of this disease, so when my patients come in for their colonoscopy, I will do an upper endoscopy depending on their findings every 1 to 3 years so we can learn more about the disease and then prevent cancer from developing. Thank you for your time. Questions? I'd love to take any questions from anyone. Yes?
I'm coming. Hi. So my son started having GI symptoms, I think at the age of 5. He had his first endoscopy because they thought he had celiac because he has type 1. And then they saw that glycogen acanthosis in the esophagus. He had a nodule in his stomach. and he also had lots of polyps. So originally they thought we had FAP, and then come to find out it's PTEN. But my question is, since then we've been doing colonoscopies and endoscopies once a year, and capsule endoscopies once a year, because he has so many polyps. Like, he had more than 50 the first time. Since he's been on the Afinitor, it was decreased to like 3 to 5 the last time. But so I just don't know if you agree with that. Once a year is sufficient for that sort of thing when you have that many polyps?
So the question is, in the Cowden's patients that have polyposis, gobs of polyps, certainly those are the individuals that I bring back on a yearly basis. And it all depends on the size, number, and pathology. But for years, even before Dr. Eng was with us, I knew much about Cowden syndrome, I would see patients that had a lot of lumps and bumps in their upper tract, and I'd biopsy them and would come back normal upper intestinal or normal stomach lining. I'd say, but it's polyposis. And now, after 20 years of managing patients with hereditary cancer syndromes. But so yes, on a one-year basis wouldn't be so unreasonable. And the point is, it's important for you to work with a gastroenterologist or a colorectal surgeon that understands the polyps. We can use different colored lights to say which ones are the precancerous ones that need to be removed versus things that are lymphoid follicles that are kind of normal part of the immune system. So we don't want to turn kids or adults into pincushions. We want to improve their health. And so for my approach to all of my polyposis patients, whether it's Cowden's or FAP, is anything that's 6 millimeters or greater in size comes out, as well as things that look funny. And I do